Hello, and welcome to another chapter of Advanced Pharmacology. Today, under Unit 20, Drugs for the Eyes, Ears, and Skin, we will speak specifically about Chapter 85, Drugs for the Skin. When one considers the vast number of skin conditions and the even greater number of pharmacologic agents used in their management, it's easy to see that the topic of dermatologic conditions alone could compromise a separate textbook. Our objective is to discuss dermatologic drugs used to manage a select group of conditions, commonly managed by a non-specialist. Most are dosed topically, some are given systemically. Before discussing the dermatologic drugs, we will review quickly the anatomy of the skin. So, the anatomy of the skin. The skin is composed of three distinct layers. We have the epidermis, the dermis, and the layer of subcutaneous fat. These layers and other features of the skin are shown in the following figure. For those of you who need a quick refresher for your pathophysiology and anatomy, take a look here. Hit pause. So, we'll briefly speak on the epidermis. The epidermis is again that outermost layer of the skin and is composed almost entirely of closely packed cells. So, again, as indicated in the figure here, the epidermis itself consists of several layers. The deepest known is the basal layer, or stratum germinativum, which contains the only epidermal cells that are mitotically active. All cells of the epidermis arise from this layer. Production of new cells within the basal layer pushes older cells outward. During their migration, these cells become smaller and flatter. As epidermal cells near the surface of the skin, they die and their cytoplasm is converted to keratin, a hard proteinaceous material. Because of its high content of keratin, the outer layer of the epidermis has a rough, horny texture. Because of its texture, this layer is referred to as the cornified layer, or stratum corneum. The surface of the stratum corneum undergoes continuous exfoliation, or shedding. The shedding completes the epidermal growth cycle. In addition to germinal cells, the basal layer of the epidermis contains melanocytes. These cells, which are few in number, produce melanin, the pigment that determines skin color. After its synthesis within melanocytes, melanin is transferred to other cells of the epidermis. Melanin protects the skin against ultraviolet radiation, which is the principal stimulus for melanin production. Bringing us to the dermis. The dermis underlies the epidermis and is composed largely of connective tissue, which is primarily our collagen. A major function of the dermis is to provide support and nourishment for the epidermis. Structures found in the dermis include blood vessels, nerves, and muscles. The dermis also contains sweat glands, sebaceous glands, and hair follicles. Sebaceous glands secrete an oily composite known as sebum. Almost all sebaceous glands are associated with hair follicles. Bringing us to the subcutaneous tissue. Subcutaneous tissue consists largely of fat. This fatty layer provides protection and insulation. In addition, the stored fat constitutes a reserve source of calories. Which now brings us to topical drug formulas. Topical drugs are provided through a number of vehicles. The most popular are our ointments, creams, lotions, gels, foams, powders, and pastes. Ointments are thick, greasy preparations with an oil or petroleum jelly base and little, if any, water. They provide the highest medication absorption of all formulas. They enhance penetration, makes it especially useful in management of conditions with thickened skin or inflamed skin. Because it provides an occlusive film that retains moisture, it is not a good choice for weeping or oozing skin conditions or in areas prone to heavy perspiration. It is often an excellent choice, however, for dry skin conditions. Creams are an oil and water emulsion. Some contain more oil than water, whereas others contain more water than oil. This affects the thickness of their consistency and how oily or sticky they feel on the skin. They are not as thick as ointments, but they are thicker than lotions. Creams tend to be good for inflamed skin and dry, sensitive skin. It may or may not be useful for oozing lesions, depending on the ratio of water to oil. Creams tend to be good for inflamed skin and dry, sensitive skin. It may or may not be useful for oozing lesions, depending on the ratio of water to oil. Creams tend to be more appropriate than ointments for their intertriginous areas. Lotions are water-based. Some may contain alcohol or acids, which can cause a burning sensation. They have little, if any, oil. As a result, they have a lighter feel than creams. Lotions are non-greasy, which tends to promote more patient satisfaction. Another advantage of lotions is that they are easy to spread, which makes them a good choice for large areas for hairy areas. They are suitable for intertriginous areas. Unlike ointments and creams, they're suitable for oily skin and may even decrease oiliness depending on the ingredients. Gels are transparent preparations that usually contain cellulose with a water or alcohol base. They liquefy on the skin contact and often have a cooling effect as they dry. Because they are non-greasy and tend to have a drying effect, gels are good choices for oily skin. They spread easily, so they are good for covering large or hairy areas. Because they dry clear and invisible, they may be more acceptable for facial regions. These may cause burning, but when this occurs, it is often the fault of the inactive ingredients rather than the medication. Foams are aerated solutions. They spread easily, dry quickly, and leave negligible residue. They tend to be a good choice for oily skin and large or hairy areas. Most powders have a talc or cornstarch base. They are dry with a silky feel that reduces friction between surfaces. This can make them useful between skin folds. The dryness of the vehicle can be helpful when applied to regions that tend to perspire, such as the feet or axillae. Pastes are mixtures of an ointment and a powder. The addition of a powder increases adherence to the skin. Because the powder disrupts the occlusive nature of an ointment, allowing for air to reach the covering skin, most pastes can be used safely in areas that are occluded, such as the use of Desitin diaper rash paste beneath a diaper. So, topical glucocorticoids. The basic pharmacology of glucocorticoids was already discussed in Chapter 56. Considerations here are strictly based for their use for skin disorders. So, we'll speak on their actions and use therefore. Topical glucocorticoids are employed to relieve inflammation and itching associated with a variety of dermatologic conditions, which would be our insect bites, dermatitis, psoriasis, eczema, and pemphigus. The vehicle in which a glucocorticoid is dispersed, whether it be a cream, ointment, or gel, can enhance the therapeutic response by helping the glucocorticoid penetrate to its site of action. The vehicle may provide additional benefits by acting as a drying agent or as an emollient. Its relative potency, therefore. Glucocorticoid preparations vary widely in potency. So, the following table here lists these drugs as to where they can be assigned to groups that range in potency from low to super high. Preparations within each group are equipotent. So here you see the relative potency of some topical glucocorticoids. An outstanding spot to hit pause so you can look at the entirety of the list. And I think this is the entirety of the list. It's important to note that the intensity of the response to topical glucocorticoids depends not only on the concentration and inherited activity of the glucocorticoid, but also on the vehicle employed and the method of application. Occlusive dressings can enhance percutaneous absorption by as much as tenfold, thereby greatly increasing the pharmacologic effects. Its absorption. Topical glucocorticoids can be absorbed into the systemic circulation. The extent of absorption is proportional to the duration of use and the surface area being covered. Absorption is higher from regions where the skin is especially permeable, and lower from regions where penetrability is poor. Absorption through intact skin is lower than through inflamed skin. So, as noted, absorption is influenced by the vehicle and can be greatly increased by an occlusive dressing. Adverse effects, therefore. Adverse effects may be local or systemic. Factors that can increase the risk for adverse effects include the use of high potency glucocorticoids, use of an occlusive dressing, prolonged therapy, and application over a large area. Local reactions. Glucocorticoids increase the risk for local infection and may also produce irritation. With prolonged use, glucocorticoids can cause atrophy of the dermis and epidermis, resulting in the thinning of the skin, striae, purpura, and telangiectasis. Long-term therapy may even induce acne and hypertrichosis. Systemic toxicity. Topical glucocorticoids can be absorbed in amounts sufficient to produce systemic toxicity. Principal concerns are growth delay in children and adrenal suppression in all age groups. Systemic toxicity is more likely under extreme conditions of use. So when there is prolonged therapy in which an area is being treated with a big doses of high potency agents covered with an occlusive dressing. When these conditions are present, adrenal suppression again may occur. Its administration. Topical glucocorticoids should be applied in a thin film and gently rubbed into the skin. Patients should be advised not to use occlusive dressings unless the prescriber tells them to. Tight-fitting diapers and plastic pants can act as an occlusive dressing and should not be worn when glucocorticoids are applied to the diaper region, for instance on infants. The same would be true of adults who wear diapers owing to their urinary or bowel incontinence. Its keratolytic agents. Keratolytic agents are drugs that promote shedding of the horny layer of the skin. They are used to treat conditions where there is an overgrowth or abnormal thickening of the skin. Effects can range from peeling to extensive desquamation of the stratum corneum. Two keratolytic compounds, your salicylic acid and sulfur, are considered next. A third agent, benzoyl peroxide, is discussed later for topical drugs for acne. So, speaking on salicylic acid, salicylic acid promotes the desquamation by dissolving the intracellular cement that binds scales to the stratum corneum. Keratolytic effects are achieved with concentrations between 3 and 6%. At a concentration above 6%, tissue injury is likely. Low, so again, 3 to 6% concentrations, however, are used to treat dandruff, seborrheic dermatitis, acne, and psoriasis. Higher concentrations, which can be as large as 40%, however, can be used to remove warts and corns. Salicylic acid is readily absorbed through the skin. Though rare, systemic salicylic toxicity, such as salicylism, can result when large amounts are used for a prolonged period. Symptoms of salicylism include tinnitus, hyperpnea, and psychological disturbances. Systemic effects can be minimized by avoiding prolonged use of high concentrations over large areas. Which now brings us to sulfur. Sulfur promotes peeling and drying. Compounds containing sulfur have been used to treat acne, dandruff, psoriasis, and seborrheic dermatitis. Sulfur is available in lotions, gels, and shampoos. It is commonly combined with salicylic acid for its additive effects. So if you're thinking, for instance, your Civex shampoo, concentrations range anywhere between 2 to 10%. Which brings us to everyone's most favorite condition, acne. Acne is the most common dermatologic disease. About 85% of teenagers develop acne, which is persistent into adulthood. Acne amounts for more visits to dermatologists rather, than any other disorder. In the US alone, the direct cost of acne exceeds $1 billion annually, including about $100 million spent on acne products that are sold over the counter. So, what is its pathophysiology? Acne is a chronic skin disorder that usually begins during puberty. The disease is more common and more severe in males. Lesions typically develop on the face, neck, chest, shoulders, and back. In mild acne, open comedones or blackheads are the most common lesion. A comedo forms when the sebum combines with keratin to create a plug with a pore. Closed comedones, or whiteheads, develop when pores become blocked with sebum and scales below the skin surface. In its most severe form, acne is characterized by abscesses and inflammatory cysts. So as a rule, acne begins to improve after puberty, and for some clears entirely during the early 20s. However, with some people, the disease continues for decades. Onset of acne is initiated by increased production of androgens during adolescence. Under the influence of androgens, sebum production and turnover of follicular epithelial cells are increased, leading to plugging of pores. Symptoms are intensified by the activity of Propionibacterium acnes, a microbe that converts sebum into irritant fatty acids. This bacterium also leads chemotactic factors that promote inflammation. Oily skin and a genetic predisposition also can contribute to this factor. Which brings us to the overview of treatment. Because acne is a chronic disease, treatment is prolonged. Fortunately, almost all patients respond well. Effective treatment will prevent scarring and limit the duration of symptomatic disease, and will thereby minimize the psychological effects of acne. Non-pharmacologic therapy. So, we do actually have options. Non-pharmacologic measures can help minimize acne lesions, especially in a patient with milder acne. Surface oiliness should be reduced by cleansing with a gentle non-irritant soap a couple times a day. Care should be taken to avoid irritation from vigorous scrubbing or the use of abrasives. Oil-based makeup or moisturizing products should not be used. Additional measures include, for some individuals, research demonstrated that dietary changes provide currently no benefit. So, drug therapy. Drugs for acne fall into two major groups, topical drugs and oral drugs. The topical drugs have two principal subgroups, are antibiotics and retinoids. Likewise, the oral drugs have two principal subgroups, antibiotics and retinoids. Occasionally, other agents, such as your keratolytic agents or hormonal agents, may also apply. So here is a table for all the drugs for acne. It's an outstanding spot to hit pause, especially for some of you that are looking into medications for yourself or someone you know. Drug selection is based on symptom severity. For patients with relatively mild symptoms, topical therapy can suffice. When symptoms are more severe, oral therapy may be required. Mild acne, again, can be managed with topical antibiotics as well as topical retinoids. Moderate acne can be treated with oral antibiotics and comediolytics. So again, your retinoids and azelaic acid. In addition, hormonal agents, those combinations of over-the-counters and spironolactone, can be used in young women whose acne is unresponsive to other drugs. The principal agent for severe acne is currently isotretinoin, also known as Clavaris or amnestine. Topical drugs for acne, therefore. Speaking now strictly on our antibiotics. Benzoyl peroxide. Benzoyl peroxide is a first-line drug for mild to moderate acne and both an antibiotic, or it is both an antibiotic and a keratolytic. Improvement can be seen within days of starting treatment. Benefits derive primarily from suppressing growth of P. acnes. The presumed mechanism is the release of active oxygen. In addition to suppressing P. acnes, benzoyl peroxide can reduce inflammation and promote keratolysis. Unlike other topical antimicrobials, benzoyl peroxide does not promote the emergence of resistant P. acnes. In fact, the drug is often combined with clindamycin or erythromycin to help protect against resistance to those drugs, which can occur when these antibiotics are used singularly or alone. Benzoyl peroxide may produce drying and or peeling of the skin. If signs of severe local irritation begins, the frequency of application need to be reduced. Benzoyl peroxide has been associated with potentially serious hypersensitivity reactions, especially in a patient who has asthma. In Canada, 131 instances of severe allergies experienced by patients who were using benzoyl peroxide and or a salicylic acid prompted a safety review. In 2015, Health Canada even issued a public warning. So there is a revised drug monograph, which will include information on sensitivity testing. Benzoyl peroxide currently is available in a variety of formulas, meaning lotions, cream, gels, and foams. Concentrations can range anywhere between 2.5% to 10%. For initial therapy, once daily application is recommended. Over time, the frequency of administration may be increased to a maximum of 3 times daily. As tolerance permits, patients should be advised to keep the drug away from the eyes, mouth, and any other mucous membranes, as well as any inflamed or denuded skin. Which now brings us to the next group of antibiotics, the clindamycin and erythromycin. Like benzoyl peroxide, topical clindamycin and erythromycin help suppress the growth of P. acnes. In addition, these drugs can decrease inflammation. Monotherapy with either drug quickly leads to the resistance. To protect against emergence of resistance, these drugs can be combined with a benzoyl peroxide. There are currently 2 fixed-dose combinations which are available, which is the clindamycin benzoyl peroxide, sold as Benzaclin, or known as Clindoxil, and then the erythromycin benzoyl peroxide, sold as benzamycin. Which brings us to the next medication, Dapsone. Dapsone, also known as Azcone, has been used for oral therapy of leprosy for decades. In a patient with acne, the drug yields the most modest decrease in inflammation and a number of lesions. The mechanism of action underlying the anti-acne benefit has not been established. Dapsone is available as a 5% gel in 30, 60, and 90-gram tubes for twice daily application. The site should be washed and dried before applying the drug, and the hands should be washed afterwards. The most common side effect of Dapsone gel is oiliness, peeling, dryness, and erythema. These effects are caused primarily by the gel vehicle and not by Dapsone. Oral Dapsone, but not topical Dapsone, poses a risk for hemolytic anemia and peripheral neuropathy. Combining Dapsone with benzoyl peroxide can turn the skin yellow or orange. Until more is known, Dapsone should be reserved for a patient who can't tolerate traditional topical treatments. Which brings us now to the retinoids we slightly discussed already. The topical retinoids, its derivatives of vitamin A, are the cornerstone of acne therapy. These drugs unplug existing comedones and help prevent development of new ones. In addition, they can reduce inflammation and improve penetration of other topical agents. Topical retinoids currently approved for acne use are tretinoin, adapalene, and tazarotene. They may be used alone or in combination with other drugs, including topical or oral antimicrobials. So, speaking now on tretinoin. Tretinoin, a topical derivative of vitamin A, is used for acne and to remove fine wrinkles. Formulations for acne are marketed as Atrilin, Aveda, Retin A, and Retin A Micro. The formulation for wrinkles, which is nearly identical to the one formulation for acne, is marketed as Renova. Tretinoin should not be confused with isotretinoin, which is a powerful oral anti-acne medication, which we will discuss a little later today. The use for acne, therefore. Tretinoin is approved again for that topical treatment of mild to moderate acne. Benefits derive from normalizing the hyperproliferation of epithelial cells within hair follicles. Tretinoin also causes thinning of the stratum corneum and can thereby facilitate the penetration of other drugs. Therapeutic effects can be enhanced by combining tretinoin with benzoyl peroxide, topical antibiotics, and oral antibiotics. For the use in fine wrinkles, tretinoin is approved for reducing fine wrinkles, tactile roughness, and mottled hyperpigmentation, also known as liver spots or age spots. In facial skin, benefits may derive from suppressing genes that code for specific proteases that break down collagen and elastin. During clinical trials, responses to tretinoin were modest. In fact, many patients achieved equivalent effects with a program of comprehensive skincare and sun protection. It's important to appreciate that tretinoin does not repair deep, coarse wrinkles or other damage caused by chronic sun exposure. Furthermore, the drug does not reverse photoaging or restore the microscopic structure of skin to a more youthful pattern. Benefits in patients older than 50 have not been established. So, its adverse effects. Tretinoin can cause a localized reaction, but absorption is insufficient to cause any kind of systemic toxicity. In patients with sensitive skin, tretinoin may induce blistering, peeling, crusting, burning, and edema. These effects can be intensified by concurrent use of abrasive soaps and keratolytic agents. Accordingly, these preparations should be discontinued before beginning tretinoin therapy. Skin reactions with two formulations, Aveda and Retin A Micro, may be less intense than those caused by Retin A, which is an older formula. Tretinoin increases susceptibility to sunburns, so patients need to be warned to apply a sunscreen with a sun protection factor or SPF of 15 or greater, and wear protective clothing. Patients again with existing sunburns should not apply this drug. Its preparation, dosage, and administration. Again, for the treatment of acne, tretinoin is available under 4 trade names: Retin A Micro, Atrilin, and Aveda. Products marketed as Retin A are available in 2 formulations, a cream and a gel. Retin A Micro is supplied as a gel, Atrilin is a gel, and Aveda is a cream or gel. There are dosages listed here. Take a peek at them. There are different levels for each. All products are administered topically, usually once a day at bedtime. Before application, the skin should be washed, towel dry, and allowed to dry fully for 20 to 30 minutes. Tretinoin should not be applied to any open wounds or to areas of sunburn or windburn. Contact with the eyes, nose, ears, and mouth needs to be avoided. For fine wrinkles of the face, tretinoin is available in a cream, which is 0.2%. Sold as Renova, the application is done again once daily at bedtime. Cosmetics should be washed off before use. Up to 6 months of treatment may be needed to see a full response, and treatment must continue to maintain that response. Adapalene, also known as Differin, is another topical anti-acne drug, which is very similar to tretinoin. Through actions in the cell nucleus, adapalene modulates inflammation, epithelial keratinization, and differentiation of follicular cells. So as a result, the drug reduces formation of comedones and inflammatory lesions. Benefits again may take between 8 to 12 weeks to develop. During the early weeks, adapalene may appear to exacerbate acne by affecting previous invisible lesions. During clinical trials, 0.1% of adapalene gel was as effective as 0.025% tretinoin gel in reducing the total number of comedones, and it was more effective than tretinoin in reducing the total number of acne lesions and inflammatory lesions. However, adverse effects are limited to the site of application. The drug is not absorbed in quantifiable amounts, so systemic effects are considered absent. However, common side effects did include burning, pruritus, or burning immediately after application, erythema, dryness, and scaling. These are most likely during the first 2 to 4 weeks of treatment and tend to start to subside as the treatment continues on. Adapalene increases the risk for developing sunburn and can intensify existing sunburns. Accordingly, all patients should apply a sunscreen and wear protective clothing. In addition, adapalene should not be used until existing sunburns or windburns have resolved. Adapalene by itself is available in 3 formulations: gels, creams, and lotions, for once daily application in the evening. In addition, adapalene is available in a fixed dose combination with benzoyl peroxide, so contact with the eyes, lips, angles of the nose, and mucous membranes need to be avoided. It is also important to avoid contact with abraded, sunburned, or eczematous skin. Which brings us to tazarotene. Tazarotene, also known as Avage or Tazorac, is indicated for topical therapy of acne, wrinkles, and psoriasis. Like tretinoin and adapalene, tazarotene is a derivative of vitamin A. For the treatment of acne, tazarotene is available in a gel. Again, there's different dosages as well as for a cream. The gel or cream can be applied to affected areas of the face each evening. The face needs to be cleaned and dried prior to its application. The most common side effects include itching, burning, and dry skin, which occurs more often with tazarotene than with tretinoin or adapalene. Like any other retinoids, tazarotene sensitizes the skin to UV light, and therefore patients need to be advised to wear sunscreen and protective clothing. Which brings us now to the azelaic acid. Azelaic acid, also known as Azalex or Phenacea, which is another topical keratolytic drug for mild to moderate acne. It appears to work by suppressing the growth of P. acnes and by decreasing the proliferation of keratinocytes, thereby decreasing the thickness of the stratum corneum. During clinical trials, topical azelaic acid was as effective as the 5% benzoyl peroxide, 0.0%, 0.05% tretinoin, or 2% erythromycin. For severe acne, azelaic acid was much less effective than any oral isotretinoin. Adverse effects, which are uncommon and less intense with tretinoin or benzoyl peroxide, included pruritus, burning, stinging, tingling, and erythema. Azelaic acid may reduce pigmentation in patients with dark complexions, so people using the product need to be monitored for hypopigmentation. Azelaic acid which is a 20% cream, is applied twice daily by gently massaging a thin film into affected areas. Contact with eyes, nose, and mouth need to be avoided. Before application, again, the skin should be washed and dried. Which brings us to the salicylic acid. Salicylic acid is another topical keratolytic drug for mild to moderate acne. For acne, the strength is 0.5% to 2%. It is available in multiple formulas: cleansers, creams, gels, liquids, lotions, and impregnated pads. As with azelaic acid, it's important to not put it in your eyes, nose, or mouth. Adverse effects again include local irritation and peeling, which is usually mild, but that the Health Canada has again issued safety alerts regarding the association between salicylic acid and severe allergic reactions. Because salicylate toxicity is not a problem when applied only to the face, however, if acne is extensive and the drug is applied to the trunk, back, and other locations, it is a potential possibility. Monitoring for signs and symptoms of salicylism, which is your hyperpnia, tinnitus, nausea, vomiting, and changes in the mental status, need to be observed. Which now brings us to the oral drugs for acne. Starting us back off with our antibiotics. Oral antibiotics are used for moderate to severe acne. These drugs suppress the growth of P. acnes and directly suppress inflammation. Oral antibiotics can be combined again with the topical retinoids. Doxycycline, vancomycin, and minosin, are considered the agents of choice. Tetracycline and erythromycin are alternatives, but resistance to these drugs is common. With all antibiotics, the benefits develop slowly, taking anywhere between 3 to 6 months to become maximal. After symptoms have been controlled with an oral antibiotics, patients need to switch to a topical antibiotic for the long-term maintenance. Which brings us to the isotretinoin. Isotretinoin, its actions and use. Isotretinoin, also known as amnestine or clavaris, is a derivative of vitamin A, which again is used to treat severe nodulocystic acne vulgaris, a condition in which this drug is highly effective for. For most patients, a single course of therapy can produce complete and prolonged remission. Because isotretinoin can cause serious side effects, its use is restricted for patients who do have severe disfiguring acne that is not responding to more conventional agents, which would include our oral antibiotics. Isotretinoin is highly teratogenic, and therefore it must not be given during pregnancy. Isotretinoin has several actions that may contribute to its anti-acne effects. The drug decreases sebum production, sebaceous gland size, inflammation, and keratinization. In addition, by decreasing availability of sebum, a nutrient for P. acne, isotretinoin lowers the skin population of microbes. Its pharmacokinetics, therefore. Absorption from the gastrointestinal tract is rapid but incomplete. Food greatly increases absorption. In the blood, isotretinoin is nearly 100% bound to albumin. The drug undergoes metabolism in the liver and possibly in the cells of the intestinal wall. Excretion is by the renal and biliary process. The drug's half-life is anywhere between 10 to 20 hours. Its adverse effects. The most common reaction is actually a nosebleed, about 80% of patients who utilize it. Inflammation of the lips, about 90%, and inflammation of the eyes, about 40%, and dryness of itching of the skin, nose, and mouth, about 80%. About 15% of patients experience pain, tenderness, or stiffness in muscles. bones, and joints. Among pediatric patients, nearly 30% experience back pain. Less common reactions include skin rashes, headaches, hair loss, and peeling of the skin from the palms and soles. Reduction in night vision has occurred, sometimes with sudden onset. The skin may become sensitized again to UV light, so patients should be advised to wear protective clothing or sunscreen if responses to sunlight start to become exaggerated. Rarely, isotretinoin causes cataracts, optic neuritis, papilledema, and pseudotumor cerebri. Triglyceride levels may become elevated, so blood triglyceride content should be measured prior to its treatment and periodically thereafter, until the effects of the triglycerides have been evaluated. Alcohol can potentiate the hypertriglyceridemia and need to be avoided. Although these adverse effects occur frequently, they usually reverse once the treatment stops. Depression. Isotretinoin may pose a risk for depression and suicide. Although proof of a causal relationship is currently lacking, nonetheless, because of the potential consequences of depression are severe, steps need to be taken to minimize the risk. Accordingly, providers should ask patients to report signs of depression or thoughts of suicide. If these do occur, isotretinoin needs to be withdrawn and a psychiatric evaluation needs to be considered. Its drug interactions. Adverse effects of isotretinoin can be increased by tetracyclines and vitamin A. Tetracyclines increase the risk for pseudomotor cerebri and papilledema. Vitamin A, a close relative of isotretinoin, can produce generalized intensification of isotretinoin toxicity. Because of the potential for increased toxicity, tetracyclines and vitamin A supplements need to be discontinued prior to the start of isotretinoin therapy. Its contraindication in pregnancy. Isotretinoin is teratogenic and must not be used during pregnancy. The drug is classified by the FDA pregnancy risk as a Category X. The risk for use during pregnancy clearly outweighs any possible benefit. Major fetal abnormalities have occurred, which include hydrocephalus, microcephaly, facial malformation, cleft palates, cardiovascular deficits, and abnormal formation of the outer ear. The iPledge program. iPledge is a very strict risk management program designed to ensure that no woman starting isotretinoin is pregnant and that no woman taking isotretinoin becomes pregnant. The iPledge program, which went into effect on December 31st, 2005, replaced all other programs designed to guard against the use of isotretinoin during pregnancy. Under iPledge, all transactions involved isotretinoin must be processed through a central automated system, which tracks and verifies critical elements that control access to the drug. The program has rules that apply to the prescriber, the patient, the pharmacist, as well as the wholesaler. Details regarding the iPledge program is available here at the iPledgeprogram.com website. Requirements for female patients. Again, each patient must receive oral and written warnings about the high risk for the fetal harm of isotretinoin when it's taken during pregnancy. Pregnancy must be ruled out prior to the initiation of the prescription and again before each monthly refill. Before the initial prescription, the patient must undergo 2 pregnancy tests, both of which must be negative. For the monthly refill, only 1 negative test is required. Each patient must use 2 effective forms of birth control, even if one of them is tubal ligation or a vasectomy of the male partner. In addition, the patient must review educational material provided through iPledge on contraceptive methods, possible reasons for contraceptive failure, and the importance of using effective contraception while taking the teratogenic drug. Birth control measures must be implemented at least 1 month before starting isotretinoin and must continue at least 1 month after stopping. Birth control is not required after a hysterectomy or for women who commit to a total abstinence from sexual intercourse. Each patient must sign a patient informed consent document designed to reinforce the benefit and risk of isotretinoin use. Each patient must also register with iPledge by her prescriber and must contact iPledge before starting treatment, once a month during treatment, and finally 1 month after stopping treatment. At each contact, the patient must answer questions on program requirements and must indicate her two chosen methods of birth control. The requirement for the prescriber, therefore. Prescribers must also register with iPledge and must agree to follow key points of iPledge programs, as described in the iPledge Program Guide to Best Practice for Isotretinoin. Also, the prescriber must register each patient with iPledge, enter the results of each monthly pregnancy test, and indicate what methods of contraception the patient is using. The initial prescription for isotretinoin and each monthly refill must also be entered into the iPledge system. Requirements for the pharmacist. To dispense isotretinoin, pharmacists must also register with iPledge and must obtain the drug through the iPledge registered wholesaler. Each time a prescription for isotretinoin is filled, the pharmacist must do the following: contact iPledge for authorization, confirm with iPledge that the prescription is no more than 7 days old, and dispense no more than a 30-day supply. Write the Risk Management Authorization or RMA number on the prescription. So, which finally brings us to the preparation, dosage, and administration. Isotretinoin is available in standard capsules, sold as amnestine or Clararis. The usual course of treatment is 0.5 to 1 mg per kilo per day for 15 to 20 weeks. If needed, a second course may be given, but no sooner than 2 months after completing the first course. Hormonal agents. Hormonal therapy can be used for acne in young women. Combination oral contraceptives and spironolactone are the main agents employed. In both cases, benefits derive from decreasing androgen activity, leading to a decreased production of sebum. Oral contraceptives. 4 combinations of oral contraceptives, estrostep, orthotricycline, Bayas, and Yaz, are approved for managing acne in women. Treatment is limited to females at least 15 years old who want contraception, who reached menarche, and have not responded to topical drugs. Acne may take 6 or more months to improve. Benefits are due primarily to the estrogen in combination. Oral contraceptives, not to the progestin. 2 mechanisms are involved: the suppression of ovarian androgen production and the increased production of sex hormone binding globulin, a protein that binds androgens and thereby renders them inactive. By decreasing androgens availability, estrogens decrease production of sebum. Although only 4 oral contraceptives are approved for acne, all estrogen containing oral contraceptives ought to work. Accordingly, selection among them should be based primarily on tolerability. So that now brings us to spironolactone. Spironolactone blocks a variety of steroid receptors, including those for aldosterone and sex hormones. Blockade of aldosterone receptors underlies the drug's use as a diuretic, as well as its use in heart failure. Blockade of androgen receptors underlies benefits in females with acne. As a rule, spironolactone is added to the regimen after an OC has proved inadequate. This sequence makes sense because spironolactone is teratogenic, and therefore contraception should be implemented before taking the drug. Adverse effects include menstrual irregularities, breast tenderness, and hyperkalemia. In 2016, the American Academy of Dermatology published guidelines for care for the management of acne vulgaris. Their algorithm for acne management is included in this chapter. The complete guide is available online at the following website, so make sure you take a look at it. So, here is now the diagnosis of acne, your first line treatment as well as your alternative treatment, whether it is for mild, moderate, or severe. It's an outstanding spot to hit pause and review so you can take a look at options. Sunscreens. Sunlight has multiple effects on the skin. In addition to promoting tanning, solar radiation can cause burns, premature aging of the skin cancer, and immunosuppression. Sun exposure can also induce photosensitivity reactions to drugs. All of these effects are caused by UV radiation and can be greatly reduced by wearing sunscreen. Types of ultraviolet radiation, UVB and UVA. So, solar radiation that reaches the Earth's surface is classified by wavelengths into two basic types, ultraviolet B and ultraviolet A, depending on the level of radiation. UVA can be further subdivided into UVA2 and 1. Most, about 95% of terrestrial UV radiation is UVA. Only 5% is considered UVB. The intensity of UVA is fairly constant from morning to evening and from one day to the next throughout the year. In contrast, UVB is significant only between late spring and early fall, and on any given day is moderate in the morning and evening, and most intense around noon. UVA can penetrate glass, whereas UVB cannot. The dermatologic effects of UVA and UVB differ. UVA penetrates the epidermis and deep into the dermis. In contrast, UVB penetrates into the epidermis but goes no deeper. Tanning and sunburn are caused primarily by UVB because UVA penetrates much deeper than UVB. UVA is the primary cause, however, of immunosuppression, photosensitive drug reactions, and photoaging of the skin. Both UVA and B promote damage to DNA, and therefore both can cause premalignant actinic keratosis, basal cell carcinoma, squamous cell carcinoma, and malignant and non-malignant melanomas. Properties of UVA and B are shown here in the following table. So another great spot to hit pause so you can see the differences. The benefits, therefore, of sunscreen. Sunscreens impede the penetration of UV radiation to viable cells of the skin. As a result, sunscreen can protect against sunburns, photoaging of the skin, and photosensitivity reactions to certain drugs. Sunscreens can also decrease the risk for actinic keratosis, squamous cell carcinoma, and melanoma. Whether sunscreens protect against basal cell carcinoma, however, is still considered unclear. Compounds employed as sunscreens, therefore. There are two categories for sunscreens, organic screens and inorganic screens. The organic screens absorb UV radiation and then dissipate it as heat. Inorganic screens scatter UV radiation. At this time, there are 17 compounds that are FDA approved for the use as a sunscreen. So in this figure here, there is an excellent spot to hit pause so you can see the different organic versus inorganic sunscreens. So we'll start off by talking about some of the organic chemical screens. Most, again, 15 of the approved sunscreens are considered organic. Almost all of them absorb UVB, but only 6 absorb UVA. Of these 6, 5 absorb UVA2 and only 1, avobenzone, absorbs UVA1. Therefore, to provide protection against the full range of UV radiation, products must contain a mixture of compounds, one of which must be avobenzone. Inorganic physical screens. Physical screens act primarily as barriers to the sun's rays. Therefore, Rather than absorbing solar radiation, they reflect and scatter sunlight, thereby preventing penetration to the skin. Only two agents are employed as physical screens: titanium dioxide and zinc oxide. Preparations containing these compounds are especially useful for protecting limited areas: your nose, lips, and the tips of the ears. In formulations that are used today, titanium dioxide and zinc dioxide are micronized. As a result, they are clear when applied to the skin, unlike older formulas which were white. Which brings us now to our sun protection factor, or SPF. All sunscreen products are labeled with an SPF. The SPF is an index of protection against UVB. The SPF says nothing about protection against UVA. The SPF is determined by shining UV light on adjacent regions of protected and unprotected skin and recording the time required for erythema, or redness, to develop in both areas. The SPF is calculated by dividing the time required for erythema to develop in the protected region by the time required for erythema to develop in the unprotected region. So, for example, if the unprotected region develops in 15 minutes, the protected region developed erythema in 150 minutes. The sunscreen would have an SPF of 10, 150 divided by 15. Be aware that the methods for determining SPF are not very precise. Therefore, all products labeled with the same SPF may not provide the equal degree of protection. The relationship between SPF and protection against sunburn is not linear. That is, an SPF of 30 does not indicate twice as much protection as an SPF of 15. In fact, as the SPF increases, the increment in protection gets progressively smaller. So, for example, if SPF 15 indicates 93% block of UVB, SPF 30 indicates a 96.7% block, and SPF 40 indicates a 97.5% block. Because SPF values above 30 provide only a small additional benefit, the FDA no longer allows companies to advertise high SPF values. Instead, products with an SPF greater than 50 can simply be labeled as SPF 50+, which I think is actually outdated. I believe we can and do actively put SPF 70, 80, 90 onto bottles at this time. Adverse effects of sunscreens. Contact dermatitis and photosensitivity reactions may occur, especially with products that contain para-aminobenzoic acid derivatives. PABA-containing products should be avoided by people with allergies to benzocaine, sulfonamides, or thiazides, all of which can cross-react with PABA. So, rules for sunscreen labeling. In 2011, the FDA released new rules for labeling sunscreens. Under these rules, the label must indicate the range of UV radiation protection and the degree of water sweat resistance. In the past, labels will continue to indicate just the SPF. The range of UV protection and SPF. All sunscreens protect against UVB radiation, but only some protect against UVA too. Products that protect against UVA and UVB are labeled broad spectrum. The label also shows the SPF, indicating the degree of UVB protection. Broad spectrum sunscreens that have an SPF of 15 or higher can claim to protect against skin cancer and photoaging. Broad spectrum agents with an SPF below 15 cannot make that claim. In fact, these products must carry a warning that they do not protect against skin cancer or photoaging. Products that only protect against UVB must carry the same warning. So, in summary, the new label will allow consumers to distinguish between three basic groups of sunscreens: highly protective, broad-spectrum sunscreens with an SPF of 15 or higher. These protect against sunburns, skin cancers, and photoaging. Moderate protection, which is broad-spectrum sunscreens with an SPF of 2 to 14, which may protect against sunburns but do not protect against skin cancer or photoaging. And then the least protective, sunscreens with UVB protection only, which protect against sunburn but do not protect against skin cancer or photoaging. Again, water and sweat resistance. Sunscreens can no longer claim to be waterproof or sweat-proof. Rather, they can claim that to be water-resistant or sweat-resistant. Furthermore, they must indicate how long the resistance lasts, as determined by the lab testing. Products that retain their SPF after 40 minutes of water exposure will be labeled water-resistant 40 minutes. Products that retain the water resistance after 80 minutes will be labeled water-resistant 80 minutes. Regardless of the stated duration of water and sweat resistance, the label must advise reapplication after swimming or sweating. So, safe sun exposure. To protect against skin damage from sunlight, we should use sunscreen and protective clothing and be mindful of the sun's hours of peak intensity. Using a sunscreen effectively. Sunscreens must be used properly to achieve maximal benefit. The American Academy of Dermatology recommends using a sunscreen with coverage against both UVB and UVA. The SPF needs to be at least 15, and an individual who burns easy should use a higher SPF product. Protection is greatest when a sunscreen has been allowed to penetrate the skin in advance of exposure to the sun. We only have one. Accordingly, sunscreens should be applied at least 30 minutes before going outdoors. Sunscreens containing PABA or patamate O should be applied up to 2 hours in advance. The amount applied is also an important determinant of protection. 1 ounce applied liberally to the body is considered adequate. Sunscreens should be reapplied after swimming and profuse sweating, and failure to do so reduces the duration of protection. However, it is important to note that reapplication will not extend the period of protection beyond that indicated by the SPF. That is, if treated skin can be expected to burn when sun exposure exceeds 2 hours, no amount of reapplication can prevent the burning if the duration of exposure exceeds that limit. So, environmental factors play a part in sunscreen use. The intensity of UVB radiation is greatest between the hours of 10 a.m. and 4 p.m. Accordingly, the need for a sunscreen is correspondingly high during that time. UV radiation can be reflected by painted surfaces like sand and snow, thereby augmenting the total UV exposure. Accordingly, the contribution of reflected radiation should be considered when choosing a sunscreen. Clouds can filter out UV radiation. Nonetheless, the amount of UV light reaching the ground on a bright day with thin cloud coverage can be as much as 80% of that reaching the ground on days that are sunny and clear. UV radiation can penetrate at least several centimeters of clear water, so swimmers should be aware of this fact. Which now brings us to other protection measures. Sunscreens alone cannot completely protect us against sun damage. Accordingly, further reduction risks need to be placed. You should wear sunglasses, protective clothing, and a wide-brimmed hat. In addition, you should avoid sun exposure in the middle of the day, especially between 10 and 4 p.m. If you must be outside at these times, try to stay in the shade as much as possible. Which now brings us to drugs for atopic dermatitis, which is our eczema. Atopic dermatitis, also known as eczema, is a chronic inflammatory skin disease. The condition is characterized by dry, scaly skin and intense pruritus that often leads to scratching and rubbing, which can lead to erythema, abrasions, rashes, erosions with an exudate, and an increased susceptibility to skin infections. Continued scratching will typically result in lichenification of the affected skin. The underlying cause is abnormal activity of T lymphocytes. First-line therapy usually consists of a moisturizer and a topical glucocorticoid. Unfortunately, glucocorticoids can cause skin atrophy, hypopigmentation, telangiectasis, and in high doses, possible systemic effects, including adrenal suppression. If a topical glucocorticoid is insufficient, patients may need to be treated with a topical immunosuppressant. A sedating antihistamine can also help control the itching and can help facilitate sleeping at night. So, topical immunosuppressants. There's two topical immunosuppressants, lacrolimus and pimecrolimus, which are approved for atopic dermatitis. Both drugs are calcineurin inhibitors. Although effective against atopic dermatitis, both drugs may pose a risk for skin cancer and lymphoma. Because of this potential for serious harm, tacrolimus and pimecrolimus are considered second-line drugs for atopic dermatitis and should be reserved for a patient who is not responding to glucocorticoids. So that brings us to the tacrolimus ointment. Tacrolimus is available as an ointment for moderate to severe atopic dermatitis. The drug relieves symptoms of attenuating local immune responses. Specifically, the drug inhibits calcineurin and thereby suppresses the activity of T cells and decreases the release of inflammatory mediators from cutaneous mast cells and basophils. The result is reduced inflammation. Systemic absorption of topical tacrolimus is low, and it gets even lower as the skin starts to heal. Absolute bioavailability is usually less than 0.05%. Blood levels of tacrolimus are usually low. Tacrolimus ointment is generally well tolerated. The most common side effect is, however, erythema, pruritus, and a burning sensation at the application site. As the skin starts to heal, these local reactions abate. In children, tacrolimus may increase the risk for varicella-zoster virus infections. Adverse effects associated with systemic tacrolimus have not occurred with topical therapy. Unlike topical glucocorticoids, tacrolimus does not cause thinning of the skin. There is, however, the concern that tacrolimus may pose a risk for cancer. The drug increases the incidence of skin cancer in lab animals exposed to UV light. In mice, tacrolimus increases the incidence of lymphoma. There have been reports of skin cancer and lymphomas in humans, although the causal relationship wasn't fully established. To reduce the risk for skin cancer, patients should protect treated areas from direct sunlight and should avoid sun lamps and tanning beds. Tacrolimus ointment is available in two concentrations, 0.03% and 0.1%. Adults may use either formula. Children ages 2 to 16 should use the lower of the two, 0.03 formula. And children younger than 2 years should not use this drug at all. All patients should apply a thin layer twice daily. Occlusive dressings need to be avoided, and treatment should be intermittent or short term. Which brings us to pimecrolimus cream, also known as Elidel, which is another topical immunosuppressant approved for mild to moderate atopic dermatitis. The drug is very similar to tacrolimus with regards to its mechanism, therapeutic effect, as well as adverse effects. Again, during clinical trials, twice daily application for 3 weeks reduced the signs and symptoms of eczema by up to 72%. The initial improvement could be seen within 2 days. Pimecrolimus may be less effective than a topical glucocorticoid, however. Although studies comparing pimecrolimus directly with tacrolimus have not been done, clinical efficacy of the drug appears very similar. Pimecrolimus is generally well tolerated. The most common adverse effect were erythema, pruritus, and a burning sensation at the application site, especially during the first few days of treatment. As with tacrolimus, there have been reports of skin cancer and lymphoma, but again, the causal relationship has not been established. Similar to tacrolimus, pimecrolimus sensitizes the skin to UV light, and therefore patients should use a sunscreen and should limit exposure to natural and artificial sunlight. Systemic absorption of pimecrolimus is very minimal, and in clinical trials, blood levels were at a low, below or limit of detection. So, as with tacrolimus, prolonged treatment needs to be avoided. Which now brings us to agents used to remove warts. Warts are small benign tumors that form in the skin and mucous membranes. They are caused by infection of squamous epithelial cells with human papilloma virus, or HPV, of which there are roughly 100 types. Most warts resolve spontaneously within a few months, but some can last for years. Discussion below focuses primarily on the management of venereal warts. So, venereal warts form around the cervix, vulva, urethra, glans penis, and anus and anal canal. Most are caused by two types of HPV, known as HPV 6 and 11. Two other types, 16 and 18, are responsible for most cervical cancers. As discussed in Chapter 53, an HPV vaccine sold as Gardasil can protect against all four HPV types and therefore can help prevent venereal warts as well as cancer of the cervix. Another HPV vaccine sold as Cervarix protects against HPV 16 and 18, so it can help prevent cervical cancer but not venereal warts. Infection with HPV can be transmitted by sexual contact. Individuals with anogenital warts should be warned that they can transmit the infection to other sexual partners. Partners of infected individuals should be examined for warts using a condom may reduce the risk of transmission. Genital warts can be removed in two basic ways: the topical drugs or with physical measures such as cryotherapy, electrodissection, laser surgery, and conventional surgery. Physical measures are much faster than drugs but also more painful. Neither drug nor physical measure can fully eradicate the virus, however, because even after a successful wart removal, the virus remains. So treatment for genital warts are shown on the following table. So here's a good spot to hit pause, and you can take a look at all the treatment and prevention of venereal warts. The drugs used to remove venereal warts can be divided into two groups: agents that must be administered by the healthcare provider and agents that can be applied at home. With both groups, application is done repeatedly until the warts disappear. Provider-applied drugs are podophyllin, trichloroacid, and bichloroacetic acid. Drugs for at home include podophylox, imiquimod, and cunacetications. All of these drugs act slowly and they all cause local irritation. The pharmacology of 6 topical drugs are discussed later. So, for the provider-applied drugs, podophyllin, which is used primarily for perianal and venereal warts. The drug is not very effective against a common wart. Podophyllin is a mixture of resins from the May apple or mandrake. The active ingredient in the resin is podophyllotoxin, a compound that inhibits DNA synthesis and mitosis. These actions eventually lead to cell death and the erosion of warty tissues. Formulation employed to remove warts contains 25% of podophyllin resin. These preparations are highly caustic and should be applied only by a trained clinician. To minimize the risk for toxicity from systemic absorption, the resin should be washed off with alcohol or soap and water a few hours after application. Each treatment should be limited to a small surface area and to a small number of warts. Podophyllin can be absorbed in amounts sufficient to cause a systemic toxicity. Potential reactions include central and peripheral neuropathy, kidney damage, and blood dyscrasias. These effects are most likely when the drug is applied to large areas in excessive amounts. Podophyllin is teratogenic and must not be used while pregnant. Podophyllin is supplied in a 25% solution for topical use. Application should be limited to small areas. Again, the drug should not be applied to moles or birthmarks, nor should it be applied to warts that are bleeding or friable, or that have undergone a recent biopsy. When used to remove a venereal wart, podophyllin should be washed off in 1 to 4 hours after application. Treatment may be repeated at weekly intervals for up to 4 weeks. Which brings us to BCA and TCA, the bichloroacetic acid and trichloroacetic acid. When applied in high concentrations between 80 and 90%, both BCA and TCA can destroy warts by chemical coagulation. Application is repeated weekly if needed. Solutions of these acids are very watery and therefore can easily spread to and thereby injure surrounding tissue. To minimize the spread, the solution should be allowed to dry before the patient sits or stands. If patients develop BCA and TCA can be neutralized with liquid soap and sodium bicarbonate or baking soda. If too much solution is applied, it should be neutralized with soap or sodium bicarbonate or removed by applying talc. The patient-applied drugs. Patient-applied drugs are used for topical therapy of external genital and perianal warts. So, like podophyllin, these drugs require a prescription. Because they are applied at home, these drugs are more convenient than the provider-applied drugs. So, imiquimod cream, stimulates the production of interferon alpha, tumor necrotizing factor, and several interleukins, and thereby intensifies immune response to HPV, the virus that causes venereal warts. Imiquimod has no direct antiviral effects on its own. Principal adverse effects are erythema, erosion, and flaking at the site of administration. Local itching, burning, and pain may occur too. Imiquimod undergoes minimal absorption and therefore systemic effects are usually absent. The cream is available in two formulas, sold as Cyclera and or Aldera. And just hit pause and take a look at the different prescription dosage. Cyclera is applied once a day for up to 8 weeks, while Aldera is applied 3 times a week for up to 16 weeks. Both formulas are applied at bedtime and washed off in the morning. Imiquimod use for actinic keratosis will be discussed a little later. Podophylax. Podophylax is similar to podophyllin, which inhibits mitosis. Whether this action underlies beneficial effects is unknown. Podophylax is supplied as a gel or solution, both of which is 0.5%, and can be applied twice daily for 3 consecutive days, followed by 4 days off. This pattern is repeated 4 times until the wart is gone, whichever comes first. Patients should wash their hands before and after applying the drug. However, unlike imiquimod, podophylax needn't be washed from the site of application. Treatment frequently causes local inflammation, burning, erosion, pain, itching, and bleeding. These can be minimized by limiting the application area to about 10 centimeters squared, applying no more than 0.5 grams per day, and avoiding application to normal skin. Podophylax causes more discomfort than imiquimod, but works faster and also costs less. Which brings us to the cunnicatachins, the ointment, also known as Virigen. It is made by the extraction of the leaves of the Camellia sinensis, or green tea. The primary active component in this extract is epigallocatechin, a compound of the catechin family. The extract also contains small amounts of gallic acid and 3-methylxanthines, caffeine, theophylline, and theobromine. Although the mechanism of action has not fully been determined, possibilities include antioxidative effects, induction of apoptosis, and the inhibition of telomerase. Cunnicatechins are supplied in a 15% ointment that needs to be applied 3 times daily until the wart begins to clear, or for 16 weeks, whichever one comes first. In one trial, treatment of a 16-week produced complete wart removal in about 53.6% of patients, compared with a 35.3% in those treated with a placebo. Adverse effects are also common include erythema, pruritus, burning, pain, erosion or ulceration, edema, induration, and a rash. Moderate reactions in patients developed up to 37%, which included severe reactions. In up to 30%, cunnicaticins is only indicated for external genital and perianal warts. It should not be inserted into the vagina or rectum and should not be applied to any open wounds. Patients need to avoid sexual contact while the ointment is present. Cunnicaticins is not recommended for HIV-infected patients, immunocompromised patients, or patients with genital herpes. Why? Because safety and efficacy in these patients has not been established. So what about your common warts? Well, common warts, also known as verruca vulgaris, manifest as a hard, rough, horny papule. These benign lesions may appear anywhere on the body, but are most common in the hands and feet. Most common warts are caused by just three types of HPV: 1, 2, or 3. Like venereal warts, common warts may be removed by physical procedures and with topical drugs. The physical methods include cryotherapy, electrodissection, curettage, and laser therapy. Pharmacologic agents include salicylic acid, podophyllin, podophylox, imiquimod, the trichloroacidic acid, and topical fluorouracil. So, now, drugs for non-surgical cosmetic procedures. I'm not going to try and pronounce that word, it's Botox, which is an acetylcholine release inhibitor and neuromuscular blocking agent. Botulinum toxin type A is a protein produced by a gram-negative bacterium, Clostridium botulinum. This is the same powerful toxin that causes botulism, a potentially fatal condition brought on by eating foods contaminated with C. botulinum. However, the doses approved for cosmetic use are much too small to produce any kind of toxic effect. In the US, two licensed Botox products are available: Botox and Botox Cosmetic. Botox Cosmetic is approved only for treating frown lines, whereas plain Botox is approved for treating cervical dystonia, detrusor overactivity, upper limb spasticity, strabismus, blepharospasms, and hyperhidrosis, and for migraine headache prophylaxis. However, except for the packaging, both Botox products are identical. The drug is available as a powder in 100-unit vials under the name of Botox. Immediately before use, the powder is reconstituted with a 2.5 ml of preservative-free normal saline to form a clear colorless solution. Accordingly, the package label reconstituted botulinum toxin is unstable and therefore should be stored cold and used within 4 hours. However, data indicate that if the drug is diluted in normal saline that contains the preservative benzyl alcohol, it retains its potency for up to 5 weeks and causes less pain when injected. So how does Botox work? Well, it's a neurotoxin that acts on the cholinergic neurons to block the release of acetylcholine. After injection, the drug is taken up by the cholinergic nerve terminals, where it inactivates SNAP25, a protein critical to the function of acetylcholine-containing vesicles. In the absence of SNAP25, the vesicles are unable to fuse with the terminal membrane and therefore cannot release the acetylcholine. Restoration of neuronal function requires sprouting of new terminals, a process that can take several months. Botulinum toxin blocks transmission of neuromuscular junctions at cholinergic synapses of the autonomic nervous system, including synapses in the autonomic ganglia. The FDA has approved Botox for reducing frown lines, known formally as glabellar lines. Botox is also used to soften lines in the forehead, the neck, and to diminish crow's feet. Botox is administered by injection. To reduce frown lines, for example, Botox is injected directly into the small muscle that produces a frown when they contract. 5 injections are made, each consisting of 4 units of botulinum toxin in 0.1 ml of fluid. 2 injections go into each corregulator muscle and 1 into the procerus muscle. The whole procedure takes less than a few minutes. Results are neither instantaneous nor permanent. Rather, muscle paralysis develops slowly over the next 3 to 10 days and fades within 3 to 6 months. Botox injections may be repeated to maintain cosmetic benefits. However, at least 3 months should separate treatment. There's no data on its long-term effects. The FDA has issued a black box warning related to the spread of toxin from the site of injection to other areas, leading to life-threatening injuries. However, this has not occurred with the small doses used for cosmetic treatment. For cosmetic treatment, and most common side effects are headache, facial pain, swelling, and bruising. Swelling and bruising can be reduced by applying ice to the site and by avoiding alcohol, vitamin E, and aspirin for the week before treatment. Injection into the wrong site or diffusion from the right site into surrounding tissues can weaken muscles that were not intended as targets, causing multiple undesired effects. Ptosis occurs in about 5% of patients and can persist for 3 to 6 months. Injections in the lower face can result in drooling, an asymmetric smile, drooping mouth, and biting of the inside of the cheek. Injections in the neck can make swallowing difficult and can change a vocal pitch. So, who should use Botox? The drug should be avoided by women who are pregnant or breastfeeding and by patients who may be allergic to human albumin, a protein in Botox preparations. In addition, Botox needs to be avoided by people using aminoglycoside antibiotics or any other agent that has neuromuscular blocking properties. The drug should be used with caution in a patient who has myasthenia gravis or any other type of neuromuscular disorder that can intensify muscle paralysis. Lastly, Botox should be avoided by people older than 65 because it's unlikely to help. In older people, the major cause of lines and wrinkles is loss of elasticity in the skin, a phenomenon that can't be reversed by neuromuscular blocking. Over time, some patients may develop antibodies against botulinum toxin type A. The only consequence is a reduction in Botox benefits. The risk for antibody production may be increased by using high doses and short dosing intervals. If antibodies do develop, patients may still respond to the product known as myoblock, which consists of the botulinum toxin type B. Which brings us to our antiperspirants and deodorants. Perspiration is produced by two types of sweat glands, your eccrine glands and your apocrine glands. The eccrine glands secrete profuse watery perspiration. The apocrine glands secrete a small volume of fluid, rich in organic compounds. The unpleasant odor associated with sweating results from chemical and bacterial degradation of the compounds in apocrine sweat. Eccrine glands contribute to odor by creating a moist environment that favors bacterial growth. Perspiration odor can be reduced with antiperspirants and deodorants. So, what is an antiperspirant? The principal compounds employed as antiperspirants are aluminum chlorohydrate, aluminum chloride, and a buffered aluminum sulfate, all of which can cause cancer and need to be avoided. These agents can decrease the flow of eccrine sweat by 20 to 50%. Reduced flow appears to result from the inhibition of sweat production and from partial occlusion of the sweat gland. Topical antiperspirants can cause stinging, burning, itching, and irritation. Dermatitis and ulceration occur rarely. Severe sweating can be reduced with botulinum toxin type A, the same drug used for smooth muscle wrinkles. Botulinum toxin inhibits the release of acetylcholine from the sympathetic neurons that innervate sweat glands and thereby reduce sweat volume. To treat axillary hyperhidrosis, 10 to 15 intradermal injections are made into each armpit. The needle employed is very fine, a 30 gauge, to minimize discomfort. One set of injections can markedly decrease sweating for 6 or more months. Deodorants. Deodorants inhibit the growth of the surface bacteria that degrade components of apocrine sweat into the malodorous products. Deodorants do not suppress sweat formation. Agents employed as a deodorant include carbamylide, trichlorocarbon, and triclosan. These antiseptics are the active ingredients in deodorant soaps, such as Dial, Lever, Tom's of Maine, and Irish Spring. Drugs for seborrheic dermatitis and dandruff. Seborrheic dermatitis is a chronic, relapsing condition characterized by the inflammation and scaling of the scalp and face. Skin of the underarms, chest, and anogenital region may also be affected. Symptoms result from an inflammatory reaction to infection with Malassezia, a microbe in the yeast family. Symptoms respond rapidly to a topical treatment with a ketoconazole, an antifungal drug with activity against yeast. For treatment of seborrhea, ketoconazole is available in a 2% cream, 2% foam, 2% gel, and either 1 or 2% shampoo. The cream, foam, and foam formula is applied twice daily for 4 weeks. The gel is convenient, being applied just daily for only 2 weeks. Concurrent use of topical glucocorticoids may also accelerate the initial response. After the yeast infection has been controlled, remission can be maintained by periodic use of a shampoo that contains a yeast-suppressing drug, again, such as your ketoconazole or selenium sulfide. Which brings us for drugs for hair loss. 2 drugs are available that promote hair growth: minoxidil and finasteride. Minoxidil is applied topically. Finasteride is taken orally. Neither drug was originally developed for baldness. Minoxidil was developed for hypertension and finasteride for BPH. So that takes us now to topical minoxidil. Minoxidil is a direct-acting vasodilator used primarily to treat severe hypertension. The drug's pharmacology was discussed in Chapter 38. Considerations here are limited to the use against patterned hair loss in men and women. Minoxidil for baldness is available in 3 formulas: a 2% solution, 5% solution, and a 5% foam. All formulations are approved for men, but only the 2% solution is approved for women. Nonetheless, all formulas are routinely prescribed for women. All formulations are applied to the scalp twice a day. The mechanism by which minoxidil promotes hair growth is unknown. One possibility is that it causes resting hair follicles to enter a state of active overgrowth. Improved cutaneous blood flow, secondary to vasodilation, does not seem to be involved. Minoxidil can delay loss of hair and stimulate hair growth. Benefits take several months to develop, unfortunately. Response rates are somewhat disappointing. Only about 1/3 of the patients experience significant restoration of hair to regions of baldness. Hair regrowth is most likely when baldness has developed recently and has been limited to a small area. Responses with a 5% solution and only 50% greater than with a 2% solution. When minoxidil is discontinued, newly gained hair is lost within 3 to 4 months, and the natural progression of hair loss resumes. In some cases, beneficial effects may even decline, even with uninterrupted treatment. Topical minoxidil is generally devoid of adverse effects. A few patients have reported pruritus and a local allergic response. Absorption is low, and systemic reactions such as hypotension, headache, and flushing are considered rare. Finasteride. Finasteride is that oral drug with 2 indications: androgenetic alopecia and BPH. For the treatment of androgenic alopecia, finasteride is sold as a 1 mg tablet under the trade name of Propecia. For the treatment of BPH, the drug is sold as a 5 mg tablet under the trade name of Proscar, which was discussed in Chapter 51. Male pattern baldness is caused by a dihydrotestosterone, a powerful androgenic hormone formed from testosterone. In balding men, the scalp has high levels of DHT, which acts on hair follicles to induce shrinkage. Finasteride promotes hair growth by inhibiting the enzyme that converts testosterone into DHT. A 1 milligram dose reduces serum levels of DHT by up to 65% after just 24 hours. In the prostate gland, levels of testosterone increase by sixfold. Regrowth of hair with finasteride is very modest. The drug has been evaluated in men 18 to 41 years old. About 50% grew any hair. Furthermore, even when hair growth did occur, the amount was small. 1 year of treatment with a 1 milligram per day increased hair count by only 12%. In older men taking the 5 milligram per day to treat BPH, no hair growth was reported. At the dosage employed to treat baldness, adverse effects are few. About 4% of men experience reduced libido, erectile dysfunction, impaired ejaculation, and reduced ejaculate volume. Orthostatic hypotension and dizziness even occurred. Finasteride is a teratogen that can cause genitourinary abnormalities in males exposed to the drug in utero. Accordingly, women who are or may become pregnant should not take finasteride, nor should they handle tablets that are crushed and or broken. Which now brings us to your aflornith for unwanted facial hair, also known as Vanica, which is an old drug with a new indication and a new formula. It's been available since the 1990s for systemic therapy of African trypanosomiasis or sleeping sickness. Now, the drug is available as a 13.9% cream for use by women to remove facial hair. Topical eflornithine acts on cells and hair follicles to inhibit ornithine decarboxylase, the enzyme required for the synthesis of polyamines, which in turn are required for cell division and subsequential hair growth. In clinical trials, the cream was moderately effective in some women and had no effect in others. All subjects had beards or mustaches that required removal via shaving, waxing, or tweezing at least twice a week. Participants were randomized to receive either the cream twice a week or the vehicle alone. So what happened? Well, substantial hair reduction did occur in about 40% of treated women in one study and 20% of treated women in another, compared with the 10% response in women receiving the vehicle alone. Among the women who did respond, benefits developed slowly over 4 to 8 weeks or more, and then faded entirely within 8 weeks of stopping treatment. It should be noted that the cream does not remove facial hair entirely. Rather, it slows hair growth, causing hair to be finer and lighter, and decreases the need for shaving or other hair removal procedures. Because the effects aren't permanent, continuous treatment is required. Very little of the topical cream gets absorbed. Only about 1% of each dose reaches the systemic circulation. The absorbed drug is eliminated intact in the urine. No metabolism occurs whatsoever. The cream is generally well tolerated, although there is some concern about the possible fetal harm. The most common reactions were transient stinging, burning, tingling, or a rash at the application site. Although the cream absorption is minimal, it may still be sufficient enough to cause fetal injury. In animal studies, there was no evidence that topical cream is teratogenic or fetotoxic. However, of the 19 pregnancies that occurred during the clinical trial, there were 4 spontaneous abortions and 1 birth defect of Down syndrome. Until more is known, avoiding pregnancy would seem prudent. The cream is supplied in a 45-gram tube, which is about a 2-month supply. Applications are made twice a day, about 8 hours apart. Women should rub the cream in thoroughly and should not wash the treated area for at least 4 hours. Cosmetics and sunscreens may be applied as soon as the cream dries. Which brings us to drugs for impetigo. Impetigo is the most common bacterial infection of the skin. The usual pathogen is a Staphylococcus aureus. Most cases are seen in children between 2 and 5, although all age groups are technically susceptible. Impetigo is highly contagious and usually spread by person-to-person contact. Fortunately, the infection is superficial and usually self-limiting. Impetigo has 2 forms, bullous and non-bullous. Bullous impetigo is caused by a toxin from S. aureus and manifests as rapidly spreading papules that may evolve into large, thin-walled vesicles. The usual location is a warm, moist area of the skin. The non-bullous impetigo, also known as crusted impetigo, is caused by S. aureus or Streptococcus pyogenes. This infection typically manifests as a single small macule or papule that evolves into a vesicle that oozes a yellow-brown exudate, which then dries into a honey-colored crust. The usual location is skin of the hands, feet, and legs. Most, up to 70% of impetigo cases are non-bullous. Impetigo is treated with antibiotics. Mild to moderate infections can be treated with a topical agent. More serious infections, however, are treated with oral agents. Dosages for representative antibiotics are shown in this following table. An outstanding spot to hit pause so you can take a look. Local anesthetics. Local anesthetics, so your benzocaine, lidocaine, pramoxine, can be applied topically to relieve pain and itching associated with various skin disorders, which include our sunburns, plant poisoning, fungal infections, diaper rashes, and eczema. The selection of topical anesthetics is based on the duration of action, desired vehicle, whether it's a cream, ointment, solution, or gel, and prior history of hypersensitivity reactions. The pharmacology of local anesthetics were already discussed in Chapter 21. The following table here shows patient concerns across the lifespan for many of the drugs discussed in this chapter. An excellent spot to hit pause and you can review. The big ones that should be noted would be your FDA pregnancy risk category. If you take a quick peek, a lot of them fall into the C or X category, as well as some Bs. That concludes our chapter here for today. As always, I thank you for listening, and I'll see you all at the next chapter. Till then, thank you and have a wonderful day.